introduce Jean, who is a PhD candidate with our group. And I have gotten to know Jean really well because we recruited him from Melbourne. He was very reluctant to come to Brisbane, but he is so much at home here that he's reluctant to go back, I think. So Jean is a very experienced pharmacist. He was working as a lead critical care pharmacist at Eastern Health in Melbourne, and he came to in 2020, is that correct, Jean? To start a PhD with us. And Jason and I are fortunate enough to be his supervisors, and he's done some great work here. So I will let Jean take over. Thank you.
Thanks, Oz, for that lovely introduction. It's great to be here in person and seeing so many familiar faces and finally doing a presentation live. Zoom's been challenging, but it's great that we're finally getting back to a semi-normal world. So now that Oz has set the scene in terms of why dosing is particularly important in the critical care setting, especially when it comes to antibiotics, I'm hopefully going to talk to you about some of the different tools that we can use in the ICU to help optimize some of the doses of the antibiotics that we prescribe in the ICU setting. So these are just some of the things that I'll be covering in my talk today. We'll broadly look at some of the different tools that are currently available to clinicians in the ICU. Some of these you'll be quite familiar with, and some of them are perhaps a bit newer to you. I'll spend a particular focus with the Bayesian dosing software programs, which is the bulk of the work that I've done throughout my PhD. We'll examine some of the clinical studies that actually looks at how this technology can be used in the intensive care setting, and some of the lists of the available dosing programs that are currently out there. So this is just a simple slide that kind of ties all of the different tools that you can use together. At its simplest, you have your clinician who, I don't know if this works. You've essentially got your clinician who empirically selects a dose that they think will get to your pharmacokinetic, pharmacodynamic, or PK/PD target based on the patient parameters. So a lot of the time, we don't actually think that this is a form of dose optimization, but it actually is. You are looking at your patient, the patient has potentially impaired renal function, and you're actually giving them a slightly lower dose to compensate for that. Now, depending on the setting that you're working in, you might have the ability to perform therapeutic drug monitoring, whereby you can actually assay the concentration of the antibiotics that the patient has resulted in. And then the clinician can then empirically alter the dose of the antibiotics based on the antibiotic concentration that's been achieved. A slightly more sophisticated way of doing that is with the help of a dosing nomogram. So I think most of us would be familiar with that in the form of vancomycin in our respective areas of practice, whereby the dosing nomogram recommends a particular dose that is likely to achieve the target that you're after based on some fixed patient characteristics. So things like age, weight, renal function. And again, if you work in a facility that has the ability to assay for these drug concentrations, the actual nomogram might have the ability to actually make a dose adjustment based on the level that you've achieved. Now, with the advent of pharmacokinetic models and the advances of computerized technology and statistical modeling, dosing software has really become more pronounced in the past 10 to 20 years, which is the focus of my PhD. So if you have a look on the right here, there's several different types of dosing softwares that exist out there in the literature, and there's several different ways of using it as well. At its core, a dosing software program can potentially recommend an empiric starting dose, very much like the dosing nomograms, whereby it thinks this is the particular dose that you need to give to your patient to achieve the target that you're trying to get. And if you're able to assay the actual resulting concentration, it can then refine the actual dosing recommendation to hopefully make it more specific to your patient. I won't spend too much time covering all the different types of dosing software, but like I said before, the main ones that I'll be covering will be the Bayesian programs. So what is this mystical Bayesian dosing software program? It's essentially a software program that utilizes a pharmacokinetic model. So these are models that predicts the impact of various covariates or patient factors that we know will impact on our antibiotic concentrations. So we're looking at things like renal function, weight, height. The software actually utilizes these two pieces of information along with information from the pathogen that you're trying to treat. So most of the times we'll be looking at the MIC or the breakpoint, and it uses all of these pieces of information together to generate an empiric initial starting dose. We can then administer this empiric starting dose to the patient, and we're able to assay the corresponding antimicrobial concentration. If we've achieved our concentration, great. But if we haven't, the software can actually utilize this concept of Bayesian statistics to actually refine the underlying pharmacokinetic model, making it more individualized to your patient. It then generates a new dosing recommendation that can then be administered to the patient. And this cycle here can be repeated as many times as required, with each subsequent dose becoming a little bit more individualized. Now, what is this Bayesian statistics? It's essentially a method whereby we predict the probability of an event occurring based on prior knowledge. And when we're looking at it from a drug dosing point of view, we're looking at the probability of you achieving your target antimicrobial exposure based on all of this prior information that we have about the patient. Now, the other thing that's a bit special about dosing software as well, and this is not specific to Bayesian dosing software programs, is that they can often estimate pharmacokinetic parameters, such as the area under the curve that Oz talked about in his presentation, just from one sample. And this can be a randomly timed sample. It doesn't have to be a trough sample or a peak sample. So that is one benefit of using this particular program. Now, some common examples that you might see in the literature include best dose, dose-me, IDODS, precise PKN, inside RX. And the benefit of this particular technology is that it tends to offer quite a wide variety of antibiotics, including beta-lactams, fluoroquinolones, and antifungals. And a lot of them can certainly optimize doses of non-antibiotic medications, so things like anticoagulants, chemotherapy, and the such. So this leads me to the first study that I want to cover that it's a study that was done by Heal et al., so one of our collaborators in the United States. And they wanted to see how effective are these programs at generating empiric doses in order to achieve the target exposures that they were trying to achieve in their patients. So this was I'm just going to move something. This was a prospective interventional study that was conducted in an American intensive care unit. And the specific population that they were looking at were patients who had gram-negative sepsis. And any patient that was receiving piperacillin, tazobactam, cefepime, or meropenem were included into this particular study. The software that they used was IDODS. And the way that the study worked is kind of depicted on the right here. So all of the patients initially received an empiric dose that was started by the clinicians based on the antibiotic dosing protocols that were was present in the ICU there. They then included this information into IDODS along with the MIC of the pathogen to determine if the empiric doses that had been selected by the clinicians would actually achieve the target that they were trying to achieve. Now, if the target was predicted to be achieved, then they would just continue on that empiric dose. But if it was predicted not to achieve that target, they would then use the recommended dose that IDODS generated and administer that to the patient. Irrespective of which group they ended up in, they ended up measuring the mid-interval concentration and the trough concentration in subsequent doses. Now, for the purposes of this study, they defined their targets for piperacillin as 50% of the dosing interval, whereby the piperacillin concentration exceeded the MIC. For meropenem, it was 40%, and for cefepime, it was 60%. So really the targets that were identified from in vitro studies. And where they were unable to use the MIC, they used the clinical breakpoints for that particular pathogen. So the slides are not moving. Oh, right, sorry, thanks. So overall, in terms of the baseline characteristics of the patients in the study, they collected data from 49 patients. 20 of them had piperacillin, 19 of them had meropenem, and 10 of them had cefepime. So this is the actual baseline characteristics of all of the patients in the study. And this is the MIC data and the antibiotic concentrations for the particular study. What you'll notice is that the actual MIC of the pathogens were probably on the slightly lower end or on the lower end of what you would normally target in clinical practice, I suppose. So I'm referring to the breakpoints when I say that. So for example, the average MIC in this study was 0.25 for meropenem, and the clinical breakpoints are usually about 2. And then it was 8 for piperacillin, and it was 1.5 for cefepime. And what they found was that in this particular study, 47 out of those 49 patients actually achieved the target concentration that they were after with the first antibiotic sampling that they performed. And the 2 patients that were subtherapeutic were patients with piperacillin tazobactam. The interesting thing was that out of the 49 patients, 11 of the patients actually received a dose change because of IDODS, and that was roughly 22.4%. So what that tells us is that if we didn't use dosing software to generate those empiric doses for these patients, potentially 22.4% of those patients would have had subtherapeutic antibiotic exposure. For reference, the dose of piperacillin that was used as part of the protocol in this particular ICU was 3.75 Q6H. For meropenem was 1 gram every 8 hourly, and for cefepime was 2 grams every 6 hourly. And the clinicians were allowed to adjust the doses of the antibiotics based on the patient's renal function as per standard clinical practice in that ICU. So what does this study tell us overall? It suggests that IDODS can probably recommend accurate or appropriate antibiotic doses for most patients who are receiving these antibiotics here. And it's potentially more effective than just using the empiric doses that are protocolized in a particular ICU. So this led us to our particular study that we did here in Brisbane, and we were really interested in a proof of concept study. We wanted to see if these technology, or rather these dosing software programs, can actually generate dosing recommendations that get our patients to target concentrations. And it's slightly different to the study that I've just covered, and I'll hope to illustrate that next. So this was a prospective observational interventional study that was done in the ICU at the Royal Brisbane Hospital, and we aimed to include anyone who was receiving piperacillin tazobactam, meropenem, vancomycin, cefepime, or flucloxacillin, who also had TDM done. Now, I will say that therapeutic drug monitoring is fairly routine in this particular ICU, and that's why we included these patients here. Now, the way that this study worked was that all patients were initially prescribed an empiric dose as determined by the clinician, so there was no dosing software used at this stage. We then measured the antibiotic concentrations that was a result of those empiric doses. Here, one of two things could happen. If the concentrations were therapeutic as determined by the clinicians, they would obviously just continue the dose that they were on. But if the concentration was subtherapeutic or toxic, we used the dosing software IDODS to actually make a recommendation of a dose that was predicted to get them to that therapeutic range. That option was then given to the clinicians, and they had the option of either accepting or rejecting that recommendation. If the recommendation was accepted, we then requested a repeat antibiotic measurement to determine if we actually got those patients to target concentrations after receiving the dosing recommendation from the software. And this cycle here could have been repeated multiple times if required. The primary outcome of this particular study was the proportion of patients that actually achieved target concentrations after using the dosing software. And we had a target recruitment of 50 patients with repeat TDM. In terms of the baseline characteristics of the patients in this particular study, we ended up collecting data from 75 patients, and out of those 75 patients, 66 had subtherapeutic exposures and 9 had toxic exposures. IDODS dosing recommendations, or the software recommendations, were accepted in 59 patients, which works out to be about 79%, and were rejected in 16. We wanted to look specifically at the reasons why the dosing recommendations were rejected. And most of the time, it was actually because the patient was being swapped over to an alternative antibiotic, or the antibiotic was going to be ceased, or the patient was about to be discharged from ICU. So there was no good reason to actually change the dose of the antibiotic. In 2 of the occasions, the patient was actually clinically improving despite of the subtherapeutic concentrations. So the clinicians elected to continue on the dose that they were on. And in 2 occasions, the clinician elected to use their own dosing regimen. We were unable to determine the actual cause or the actual reason in 2 patients. Of the 59 patients, we managed to get 50 patients with repeat therapeutic drug monitoring measurements. And 20 of them came from meropenem, 13 from piperacillin, and 17 from vancomycin. We did have a couple of patients who received fluclox and cefepime, but unfortunately we were unable to get a repeat antibiotic measurement for those patients. This is just the baseline characteristics of all the patients that were included in this particular study. So it's been divided up into the individual antibiotics and collectively the 50 together. So overall, fairly similar characteristics, certainly no statistically significant difference that we could see between the different groups. What we noticed was, of the 50 patients, 43 patients actually achieved the target exposure after 1 dosing recommendation, and that was equivalent to 86%. Now, when we look specifically at the individual drugs, with the meropenem, we had 20 patients. 19 of those 20 patients achieved the target after one dosing recommendation, which was 95%. And of these 20 patients here, 18 of them were initially subtherapeutic and 2 were toxic. There was one patient that still remained subtherapeutic after the dosing software intervention, but unfortunately they were discharged to the ward before we were able to collect another TDM level. When we look specifically at piperacillin tazobactam, we had 13 patients and 11 of them were therapeutic after one dosing recommendation, so 85%, and all of them were initially subtherapeutic. Unfortunately, one of them was actually discharged to the ward before we could repeat the dosing simulations, and the other patient was actually switched to an alternative antibiotic. And lastly, for vancomycin, we had 17 patients. 13 patients were therapeutic after one recommendation, which is equivalent to 76%, and 16 of them were subtherapeutic initially, and one of them were toxic. When we look specifically at the 4 patients who didn't achieve targets, those 4 patients actually developed supratherapeutic concentrations. And I will say that in these patients, we're actually targeting concentrations of 20 to 25, as opposed to 15 to 20. And what we saw in these patients is that they achieved concentrations of 27, 29, 31, and 32. So even though they were slightly higher, they were by no means excessive of what we would see if a clinician were dosing these patients here. And the reassuring thing was that in 3 of these patients, after receiving a second dose from the dosing software program, they achieved the targets that they were trying to achieve. And in the 4th patient, the antibiotic was actually ceased before we could do that. So overall, it appears that IDODS can generate appropriate recommendations for most patients who are on meropenem, piperacillin, and vancomycin. And the vast majority of patients will achieve that target just after one dose, and less than 20% will require more. And even when we did achieve those higher targets, it was certainly not excessive of what we would see at baseline. I'm feeling my slides have moved, but that's okay. So the next thing that we wanted to see or examine was, what was the actual clinical impact of integrating this technology into the workflows in the ICU? So in order to do that, we conducted a before and after prospective interventional study called the DIRECT study. So this was a multi-center study that occurred across 4 different ICUs. 3 of them were adult ICUs and 1 was a pediatric ICU. We recruited patients who were on piperacillin tazobactam, meropenem, flucloxacillin, vancomycin, cefotaxime, and ceftazidime. And the primary outcome that we were interested in this particular study was actually the time that it takes to achieve a trough concentration for these antibiotics that exceeded the MIC of the pathogen. And where we didn't have the MIC, we then elected to use the clinical breakpoints. So in terms of the study protocol, there was a pre and a post phase. So in the pre-phase, antibiotics were dosed according to the standard clinical practice across all of the different ICUs. But in the post phase, the dosing software IDODS was used in conjunction with the prescription of the antibiotic dose, in a very similar fashion to the previous study. So again, clinicians elected to start the patient on whatever dose they think was appropriate for the patient. We then measured the antibiotics. If it was subtherapeutic or toxic, we then used the dosing software to give an optimized dose, and then we repeated the measurements after that. Now, antibiotic sampling in this particular study occurred at 24, 48, 72, and 96 hours. And because there was quite a bit of variability in each 24-hour window in terms of when the actual collection was done, we actually used IDODS to simulate the exact time that the patients achieved those target concentrations using these measurements here. Antibiotic targets were identified from the MIC of the pathogen, as I said, using an e-test available. And if it weren't, we used the clinical breakpoints, which were essentially the UCAST clinical breakpoints. Now, the analysis was actually done in antibiotic events as opposed to patient numbers, and that was primarily due to the fact that some patients were actually on more than one study antibiotic, so we elected to analyze each antibiotic as its own individual event. So this is the baseline characteristics of the patients that were included into this particular study. So we've got the pre-phase here and the post-phase, and these are the number of patients. In orange, we've got the characteristics of the patients who are adults, and then the pediatric patients and the actual number of antibiotics events as well. You will notice that we had a lot more patients in the pre-phase compared to the post-phase. And I think that might have been because we had this really annoying virus that ended up coming to Brisbane that might have messed with our recruitment numbers, but I might be wrong with that. But overall, the characteristics were fairly similar between the pre and the post phase. So when we actually look at the primary outcome, which was time to target concentration in both the MIC, what we noticed was that there was a slight reduction in the time. So it was 32.9 hours in the pre-phase and 22.8 in the post-phase, but it didn't really reach statistical significance. So that made us go back to look at the actual data that we had. And what we discovered was that a large proportion of patients actually achieved those target concentrations within the first 24 hours. So all of these patients would not have received the dosing intervention anyway because they were already at target. So what we thought was that the large amount of therapeutic patients in the first 24 hours was potentially masking the impact of the dosing software intervention. So what we then did was to look specifically at the patients who had not achieved the target concentrations in the first 24 hours in both the pre and the post phase. And when we looked at that, in the pre-phase, there were 35 events that didn't achieve target, so roughly 32.4%, and that's the breakdown between the adult and the pediatric cohorts. And in the post-phase, it was 20 events, so fairly similar numbers at 37.7%. And when we did that, that's when we noticed the big difference in terms of the time taken. It was 69.1 hours in the pre-phase and 38.6 hours in the post-phase, and that did reach statistical significance. Now, when we actually look at the descriptive results of the software recommendations, with the 20 patients, they all had subtherapeutic antibiotic concentrations, and all of the dosing software recommendations were accepted by the clinicians. We had 14 pediatric patients and 7 adult patients, and 9 of them were receiving piperacillin, 1 was on meropenem, 6 on vancomycin, 3 on cefotaxime, and 1 on flucloxacillin. 17 of these patients achieved target concentrations after 1 dosing recommendation, so very similar to the previous study. 1 event achieved it only after 2 recommendations, and that was a patient who was on piperacillin. And 2 events didn't actually receive the target concentration after 1 recommendation, and that was a patient with fluclox and vancomycin, but unfortunately they were discharged from the ICU before we could actually repeat the dosing simulations. So overall, taking into account that we have small numbers, it seems to suggest that IDODS can actually reduce the time that it takes to achieve the target concentration that you're after in the ICU. And similar to the other study, for the vast majority of them, it's only going to take 1 dosing recommendation. So I've talked a lot about the program IDODS, which brings up a question: what other programs are actually available out there, and what are the characteristics of these programs? So to answer that particular question, we conducted a systematic search of the literature to identify all software programs that had the ability to provide dosing support for antibiotics. Once we identified those programs, we subsequently sent a survey to all of the software developers to actually look at the characteristics of each individual program. And what we found was that there was at least 18 programs that had the ability to provide dosing recommendations for antibiotics. And the vast majority of them did indeed use Bayesian forecasting technology. I suspect the numbers are slightly higher because we didn't receive responses from 2 software developers, so it potentially was up to 16. Some of these devices are actually registered as medical devices, so if that's a requirement in your particular health service to adopt this kind of technology, these are the ones that you might potentially be interested in looking at. And an interesting question that we asked all of the software developers was that we asked them to provide us with evidence of the efficacy of their particular program. And majority of them did provide us studies, such as the ones that I've described, looking specifically at their program, but none had actually included data comparing one software program to another. So what that really means is that at the current timing, we don't actually have any evidence that one software program is superior over to another. So the choice of software program that you take is probably more likely to be related to the characteristics of the program and whether it suits your local needs or not. So I don't have time to cover all the different characteristics of the programs because of time restraints, but if you're interested in the results of that particular survey, it's already been published in CMI. So just as an overall conclusion, I've kind of demonstrated that Bayesian software programs are quite appropriate at generating dosing recommendations that achieve targets, and that's with or without the use of therapeutic drug monitoring. And integrating this dosing software into the ICU seems to actually reduce the time that it takes us to get to target concentrations of various antibiotics. There's always future directions with all the different studies, so it'd be interesting to see if there's actually any difference in clinical outcomes when we use dosing software compared to just clinician-based dosing. In the studies that I've covered today, the studies are pretty much split into empiric dosing or TDM-based dosing. So it would be interesting to see if there was an improvement in the time taken to achieve target concentrations if we combined both of those studies together. Obviously, I've only looked at antibiotics, so it'll be interesting to see if things like antifungals or antivirals exhibit the same findings. And lastly, the cost effectiveness of these programs as well. There are some data to support that in the ward-based setting, but probably not in the ICU. Just some acknowledgements. I'd like to thank the NHMRC for providing me with a postgraduate scholarship. The BDHP and MRFF funds for funding some of the studies that I've described here today. The Royal Brisbane ICU Pharmacy team, who are instrumental with communicating some of the dosing software recommendations in the second study, and to the direct pharmacists as well, who were instrumental with the dosing recommendations in those studies. And with that, I'll pass you back on to Oz. Thank you.
Thanks, Jean. That was fantastic.